Hello everyone, I'm Dr. Nobukatsu Ishikawa of the Research Institute of Tuberculosis. Today, I would like to talk on the topics of tuberculosis control and community engagement. This session aims to help managers of TB control programs or other services understand and discuss the importance of TB and TB services in communities and the significance of community engagement that community engagement promotes the local health system and community empowerment, and the key role of health volunteers as community health workers. I would like to begin by listing some keywords or slogans used in global strategy related to health. First, we have End TB by the WHO TB program for TB control. Second, UHC, Universal Health Coverage by the WHO for global health. Third, the SDGs, Sustainable Development Goals by the United Nations for global development. I think UHC is the expanded concept of primary health care. I show these slogans in the figure, where End TB is partially out of the circles due to its technical details. Community engagement is a concept included in all the above slogans. It has also been expressed as community participation or community empowerment. Activity with the community engagement is expressed as community care or community-based care. Let me first summarize what TB is. TB is among the 10 leading causes of global death. TB places its heaviest burden on the world's most poor and vulnerable, aggravating existing inequalities. Due to TB, people suffer much income loss. 1/4 of the global population is already infected with TB and at risk of developing the TB disease at any moment. 1/3 of people with TB cannot receive the necessary TB services due to various barriers. TB is everywhere in the world, and no country has ever eradicated it. Here, we see the global distribution of TB incidence in relation to GDP in each country, as well as the disparity in the world, with a higher TB incidence in poorer countries. One of our global targets is to reduce the incidence rate down to a low rate of 10 in 100,000 by 2035. TB is a disease with special characteristics. It is a chronic infectious disease, and its bacilli, Mycobacterium tuberculosis, are transmitted mainly through the air from person to person. So it is difficult to avoid infection in daily life. The disease has a chronic course, developing slowly with non-spec symptoms. An infected person has a lifelong risk of developing TB, but only 10 to 20% of infected persons develop the disease. Methods of diagnosis and treatment are moderately established. Moreover, the treatment needs 6 months or more of medication, so TB patients often abandon treatment. Finding a way to maintain adherence to treatment is essential for a successful cure. Diagnosis is made based on symptoms, X-ray examination, bacteriological tests such as smear, culture, or PCR, including GeneXpert, and blood tests. Among them, bacteriological confirmation is the most important. Usually, tests are done based on the suspected symptoms, but some patients with bacteriologically positive results show no symptom. Infected persons who have not yet developed the disease, whom we call persons with LTBI or latent TB infection, which is judged by a blood IGRA test, may develop TB later and need preventive treatment. These services are not always available or accessible to many due to a range of barriers, so figuring out how to get the services to reach these hidden patients is essential for wider coverage. Our country's TB program needs to be maintained over several decades. Here, I come to the component of community engagement. Community engagement is a crucial key for ending TB. The Declaration of Alma-Ata says people have the right and duty to participate individually and collectively in the planning and implementation of their health care. This is simply expressed in health by the people in primary health care. Through engaging with a wider range of partners in the community, TB service coverage becomes wider and strengthened. Community health volunteers or community health workers are key players who are closest to the needy population in the community. TB services in communities are strengthened by being integrated into the overall health system under UHC and under social welfare protection, especially for the poor, under SDGs and vice versa. In short, UHC development in the context of the SDG strengthens TB control services, and strengthening TB control service develop UHC. Let me look at the concept schematically. The government service system usually has a limited reach throughout communities. Community participation bridges the gap. Both top to bottom and bottom up are necessary for any social change and development. Coming back to the practical TB services in most countries now, government TB services are basically available. But in actuality, only 60% or less of patients are found and treated properly. Why? Because people are not aware of TB, health facilities are too far or difficult to visit, or facility capacity is still poor. So community care is needed for finding and properly treating as many TB patients as possible in the community. Where are TB patients? TB patients are everywhere, but services are limited. Health centers cover only a few of them. But in the community, there are various resources, including village doctor or drug sellers. Community health workers or health volunteers are potential alternatives. What can community and community care do? Here, community represents local authorities, community organizations, NGOs, and community health workers or volunteers. It can provide health education and information to people in the community, find hidden patients, advise visits to health centers, help patients taking drugs regularly, set up a local TB program committee, request facility to improve quality, collaboration with other programs such as HIV, MCH, and schools, and so on. I would now like to present community TB care examples from my own experiences in Bangladesh, Myanmar, and Japan. I have been working for Bangladesh for over 40 years. The TB situation in the 1980s was serious before DOTS by the WHO was introduced. TB prevalence with a positive sputum smear for those who are over 15 years old was as high as 700 to 900 per 100,000. The national TB program was so limited that only 10% of the existing TB patients were detected and not properly treated. and 90% of those TB patients defaulted from treatment. TB was a fatal disease, particularly in rural areas. The community-based TB program was piloted in a rural district of Manikganj, Bangladesh from 1984 to 1989. The population was about 150,000. There was a sub-district health center with 2 medical doctors, but no TB services were available. There were community development activities implemented by an NGO called BRAC with 200 community health volunteers or CHVs for primary care, but TB services were not included. So, the health volunteers were trained for TB case finding and treatment, and the trial, community TB care, was started. After a while, I visited the village and asked the health volunteer, Mrs. A, "Have you found any TB patient?" She replied, "Yes," and took me to her neighbor. He was seriously ill and could not even stand. So I sent his sputum to the center, and TB germ was found. So I have been giving him TB medicine every day. Now he can sit. "Doctor, I found this patient and I am treating him," she spoke proudly. I said, "Shabash," meaning well done. I came to understand that my role is not treating patient myself, but telling the volunteers, "Well done." Another health volunteer, Mrs. B, said, "My first patient was my husband. He was coughing a few weeks, and I sent his sputum out for testing, and the TB germ was found. I am treating 2 more patients who came to me for help." After 20 years, I visited the village again and interviewed Mrs. B. Asked her, "Have you faced any pressure or oppression from the community against your work?" She replied, "Yes, very much, in the beginning. The big people in the village came to my house and shouted, 'You stop your work. Muslim women should not go around freely.' Then what did you do?" I asked. "We volunteers just continued our work," she said. They calmed down because we are doing good work, and people saw that sick people were getting better. Later, one big man came to me once, quietly asking, "Mrs. B, my relative seems to have TB. Can you treat him?" Later, she has been elected as a village council member. While we were talking, she had her cell phones, which kept ringing. "What did you talk about over the phone?" I asked. She said, "A village man requested that I bring up an important issue to the village council." She has been socially empowered through her work. I asked another health volunteer, Mrs. Shi, "Why are you working as a volunteer?" She replied, "Shebakora Anondo," meaning helping others is my joy. I came to understand that all people, even the poor, have a great potential resource deep inside them, the desire to help others. It is our job to help them tap into that precious resource and cultivate it. The community-based TB program was established in this area, and in 5 years, 280 TB patients were found and treated by 200 volunteers. This pilot started as a small program launched by an NGO. Later, when a national DOT system was started after 1994, supported by WHO, the government's sub-district health center could only treat those who were living near the center. It was felt necessary to include more patients who were in remote area in the DOTS program, where NGO were providing TB care with community health workers. This led to the collaboration between the government health center and the community-based NGO program. Comparative study on delay analysis by Akramul Islam of BRAC show in the WHO bulletin that the patients in area with community health volunteers were diagnosed much earlier than those in area without community health volunteers, and concluded that the community-based program was cost-effective. This joint program has been widely expanded by BRAC together with the government throughout Bangladesh, reaching over 100 million people by 2019, which is nearly 60% of the whole population. This is an overview of the TB prevalence in Bangladesh between 1980 and 2016, according to the National Prevalence Surveys. In the 1980s, the prevalence rate of sputum smear positive patients above 15 years of age was as high as 700 to 900 in a population of 100,000. While in a 2016 survey, that figure was shown to be much lower at 113. And as for service outcome, case detection improved from 10% to 75%, and the treatment success rate went from 10% to 95%. We can see remarkable progress in 40 years. This is due to the progress of primary health care with the DOTS program all over the country. The key is that 7% of TB patients are helped by NGO in local area thanks to the strengthened community engagement. Let us move to Myanmar. In the early 2000s, only 60% of the estimated number of patients had been detected in the country. So a pilot project of community-based TB care was trialed in Pimmana, Naypyidaw with the JICA project from 2012 to 2015. Training and workshop with community health volunteers were conducted. After the training, a TB volunteer detected a TB patients while providing health education in the community. The patient had been coughing for over 3 months. The volunteer felt her badge and certificate was useful for her work. A local leader provided his house for TB meetings. Another local leader, working as a health volunteer, himself provided his house for TB work. Workshops with related partners such as health staff, volunteers, managers, and local leaders were conducted quarterly to evaluate the activities. This is the whole picture of the community TB care activities. We understand that these activities strengthened networking among related partners, and the local health system was empowered. The key points are strong leadership provided by the regional health authority, collaboration between the township hospital and community, administrative support for community health volunteers, and quarterly review meeting with partners, thereby strengthening program quality and networking. The key points for CSB regarding selection and support are: it is desirable that the nurses in rural clinics select the community health volunteers, so the relationship between health staff and community health volunteer is easily established, and the referral of suspected cases becomes easier. Community health volunteers need to be recognized and appreciated by the community leaders. The position of community health volunteer improved after the regional health director requested the local authority to acknowledge CHVs in the community. The continuous support and appreciation of community health volunteers are important. The badge and certificate are useful for community health volunteers. This project has become a national model for community-based TB care. Our last example is community participation in TB control in Japan. TB was the top cause of deaths in Japan during and after the World War II, before 1950s as well. But after the 1950s, TB started declining very rapidly since the introduction of the TB prevention law. As positive social background factors, we can cite economic development, democratization, the National Health Insurance Scheme, public-private mix, and technical development, especially effective TB drugs. In terms of community participation, I would point out TB Patient Alliance and the case of the Asahi lawsuits and the Anti-TB Women's Association. Shigeru Asahi developed TB at the age of 20s and had been hospitalized with his severe TB. His financial situation was so poor that he struggled to obtain minimum economic support. Though a social security scheme existed, the support at that time was so inadequate that he first appealed to the local government for an increase up to the minimum level. As the appeal was locally rejected, he finally filed a lawsuit in 1957 against the Minister of Health for minimum support of humane living, which is secured by the Constitution. Constitution Article 25 says, all people shall have the right to maintain the minimum standards of wholesome and cultured living. Over the course of a 7-year court trial, he died at the age of 50, and the suit was ended. But through this trial, discussions were made on the minimum standards of wholesome and cultural living, and Japan's social security welfare services were improved to a great extent. Next is the Anti-TB Women's Association. In 1957, due to a TB outbreak at a primary school in Nagano Prefecture, the Women's Society of the prefecture started a movement for TB prevention by women. This movement was expanded to many parts of Japan, and in 1975, a nationwide federation of women's societies were developed into the Anti-TB Women Association. As background factors of this development, we can cite the factors of post-war nationwide movement for women's liberation, active women's clubs in communities, proactive networking between the various groups, and the active participation of Princess Chichibu as the patroness of the association. The activities of the Anti-TB Women's Association are encouraging residents in the community to undergo health examination, promoting the SEAL campaign and fundraising, participating in seminars and training, co-organizing National TB Prevention Week, putting out a newsletter and magazine, participating in study tour to countries where the SEAL fund is used, conducting advocacy activities, and visiting mayors or politicians of the local and central government. This has become a model of community participation in Japan and has expanded its area of activities to the prevention of lifestyle-related diseases and promotion of happy and healthy aging. As we approach the end of our session, let us look at an overview of the current global progress being made towards global targets. For SDGs and end TB strategy from 2015 to 2020, the TB incidence rate reduction was only 9% against the expected 20%. The number of TB deaths only 14% versus the goal of 35%, and catastrophic cost only 49% against the target of 0. Similarly, for the targets set at the UN high-level meeting on TB from 2018 to 2022, only 14 million treatments were achieved out of the goal of 40 million. And only 6.3 million preventive treatments were achieved out of the target of 30 million. Progress has reached less than half the targets, and it is awfully slow. We must strengthen and speed up our activities. Coming back to the end TB strategy developed by the WHO spanning the years 2016 to 2035, we see 3 pillars and components: integrated patient-centered care and prevention, bold policies and supportive systems, and intensified research and innovation. Each pillar has several components. Among them, in the second pillar, we see engagement of community, civil society organization, and public and private care providers. Here lies the need of community engagement. As further raising material, the TB engagement booklet published by the WHO may be useful. In conclusion, promotion of community TB care with a community engagement approach is essential to TB control to end TB. It can strengthen networking, staff capacity, the health system in the community, and eventually universal health coverage, thus contributing to the achievement of the SDGs. If the approach is routinely practiced, it can strengthen the area's capacity to deal with other communicable or non-communicable diseases, including newly emerging diseases such as COVID-19. Global strategy, as well as our society, may be changing along with the environment. But the basic concept of health by the people must not change. However, we need to do field trials and operational research when any policy is adopted, as the practical application varies according to the area, depending on the background factors. Finally, I do hope you can start or strengthen community care with community engagement approach in your field. I'd like to leave you with some questions to consider that may be useful. Does any political or administrative commitment exist? Are there any social resources in your field, such as NGOs, CSOs, groups, community leaders, or community volunteers? Are any of what kind of incentives for volunteers needed? How can workshop for monitoring and evaluation be conducted? Is it possible to conduct a field trial or take a model approach? What type of new communication tools or digital technology, including smartphones, can be used? I encourage you to document your activities and share your experiences with us. We eagerly await your feedback. Thank you very much.